Today's topic for the discussion is anatomy of the anterior abdominal wall. This is Dr. Yusuf signing from Al Jouf University. These are the specific objectives which we will cover in this lecture. The first one is describe the formation of the anterior abdominal wall regarding its muscles, aponeurosis, fascia and ligaments. The second is describe the rectus sheath at various levels, namely above the costal margin, between the costal margin and the arcuate line, and below the arcuate line. The third is list the contents of the rectus sheath. Fourth is define the inguinal canal and its various boundaries. Next is explain the mechanics of the inguinal canal. The sixth is list the structures passing through inguinal canal in both male and female. Seven is define hernia. Eight is compare the direct and indirect inguinal hernia. Nine is explain the basis of other hernias related to GIT, namely the umbilical hernia, diaphragmatic hernia, incisional hernia, femoral and epigastric hernias. The last one is outline the different surgical incision and conventional lines which divide the abdomen into various quadrants. So these are some of the specific objectives around which our lecture will revolve. To begin with, the abdominal wall is actually divided into two parts, the anterior abdominal wall as well as the posterior abdominal wall. In this lecture, what we will be covering is the anterior abdominal wall. So in some other lecture, we'll try to cover the posterior abdominal wall, but in this, as I said before, it will be the anterior abdominal wall. So the anterior abdominal wall is made up of multiple layers of muscles and fascia. So that we'll study one by one. Okay, and this is a very important structure which will be sturdy in nature, as well as it helps in protection of the viscera which are deep inside the abdomen. So abdominal wall is very important in protection of the structures deep inside, and it also encloses the whole of the abdominal cavity. And as you know, there are major structures which are, or the organs which are deep inside, like the stomach, the intestine, the liver. So many structures are there deep inside the abdomen. And this abdomen will be divided into 9 quadrants by the presence of 2 vertical and 2 horizontal lines. These quadrants are important because if you want to approach any particular structure at that time, we'll mention that it is present in particular quadrant. So in that fashion you will be easily able to trace the that particular structure in that region. Okay, so if you want to trace the spleen, we'll mention it is present in the left hypochondrium. And if you want to talk about the liver, it will be occupying more than one quadrant, like the right hypochondrium, the epigastric, as well as even partly it enters into the left hypochondrium. If you want to talk about the appendix, we mentioned that it will be present in the right iliac fossa. So in this fashion, this will help in identifying the structures or tracing that particular structure in that particular quadrant. The 9 quadrants are formed by 2 vertical and 2 horizontal lines. The 2 vertical lines are on either side. These are the mid-clavicular line, the line passing through the midpoint of the clavicle, and it vertically runs downwards, and it also passes through the midpoint of the inguinal ligament. Okay, so these are called as the mid-clavicular line. Similarly, on either side, right and left. Similarly, we have 2 horizontal lines. The first horizontal line is called as the subcostal plane because it will be passing below the costal cartilages, the lowermost part of the costal cartilages, and joins on either side. So this is called as the subcostal plane because it is below the costa, the ribs. And the second plane is called as the intertubercular plane because this will be connecting the 2 tubercles on the iliac crest on either side. So this is called an intertubercular plane. Then we have the subcostal plane. These are the 2 horizontal lines, and 2 vertical lines. These are the midclavicular lines on either side. So this will divide the whole of the abdomen into 9 quadrants. So now what are the quadrants? One is the hypochondrium on either side. This is the left hypochondrium. Similarly, we have the right hypochondrium. So these are the 2 right and left hypochondria. Then in the middle we have the epigastric region. This is the epigastric region. Similarly, on just opposite to that, below we have the hypogastric, or it is also called as the pubic. Okay, so this is the epigastric, so this becomes a hypogastric or pubic. And here, because there is umbilicus, this is called as the umbilical region or the quadrant. Then here on either side we have the left lumbar as well as the right lumbar. Then below here we have the left iliac and the right iliac. So these are the 9 quadrants: the right and left hypochondrium, left and right lumbar, and left and right iliac regions, then epigastric, then umbilical, as well as the hypogastric, or it is also called as the pubic region. So these are the 9 regions or quadrants which are formed by 2 vertical and 2 horizontal lines. So these quadrants are important to trace any particular structure and give the incision and trace the particular structure. Okay, so this is about the quadrants. Now let's study the layers which together form the abdominal wall. So the layers of the abdominal wall consist of the external to the internal wall, or from outside to inside. These are the structures from beginning from the skin. If you see this picture, there is the skin here, and then we have deeper structures. Similarly here, if you can see, once you start incising, that will be the first will be the skin. Then you trace the superficial fascia. Superficial fascia is very typical here because it has 2 layers, especially in the lower part of the abdomen, where it is called the superficial layer of fatty layer, that will be called as the camphorous fascia or fascia of camphor, and deep inside there is membranous layer which is called as the scarpa's fascia. So these are the 2 layers which are very typical to the abdomen, especially in the lower part. One part of the superficial layer will be the fatty layer, and deep inside we have the membranous layer. Then going deep inside, after this the superficial fascia, then going deep inside we have trace the abdominal wall made up of muscles. So the first one will be the external oblique. Inside, deep inside, will be the internal oblique. Deepest will be the transverse abdominis. These are the 3 muscular layers which will be present. Then deep inside, if you go there, there will be a fascia. This is called as the fascia transversalis, which will separate the abdominal contents and the peritoneum from the muscles. So this is called as the transversalis fascia, and deep inside that will be the peritoneum, and there later we have all the organs deep inside. So this is how you can trace the structures from outside to inside. The most superficial with the skin, then the fascia, superficial fascia, especially as I said, there are 2 layers: fatty layer which is called as the fascia camphor, and then deep inside we have the membranous layer which is called as the fascia scarpa. Then we have 3 muscular layers: external oblique, internal oblique, and transverse abdominis, and deepest will be the transversalis fascia, and deep to that will be the peritoneum. Now let's study the muscles which will be forming the anterior abdominal wall, the main muscles which will be giving the strength to the anterior abdominal wall, as well as their aponeurosis. They are in pairs, so on either side. The first muscle will be the external oblique. As the name indicates, it is externally present as well as obliquely placed. So that's what is called external oblique. Then deep to that, if you cut this muscle, then deep inside you can see the internal oblique. We'll see this muscles again in detail later. Then deep inside will be the internal oblique. Deepest will be the transverse abdominis. So these will be the 3 layers of muscles in the anti-abdominal wall. Apart from that, there is also a muscle in the just beside the midline on either side. This is called as the rectus abdominis. Rectus abdominis. Okay, we'll see this muscle also. Then there are 2 smaller muscles. One is called as the cremasteric muscle or cremaster muscle, which will be present only in case of male. And then there is a small pyramid shaped muscle which is called as the pyramidalis. To begin with, the first one is the external oblique, which you can see here. So this is the external oblique muscle. As I said, it is, the name indicates, it is externally present deep to the skin and the superficial fascia. Then it is obliquely placed. So what is the origin of this muscle as well as insertion? The origin of this muscle is from the lower 8 ribs. So that is the 5th, 6th, 7th, 8th, 9th, 10th, and 11th and 12th ribs. So this will be the origin of this muscle. You can see here. So it is taking origin from the lower 8 ribs, and these fibers will run downwards as well as medially. The direction of these fibers can be imagined by putting your hands in your pockets on either side, and imagine the direction of your fingers will be the direction of direction of fibers of this external oblique muscle. Okay, so this is how it will look like. Okay, so the insertion of this muscle will be into the anterior two-thirds of the outer lip of the iliac crest. Iliac crest, as you know, this is the iliac crest. So there are three important distinguishing parts here. The outermost will be called as the outer lip. Inside we have the inner lip, and in between we have the middle surface. Okay, so outer lip, inner lip, as well as the middle broad surface. Okay, so this muscle will be attached to the anterior two-thirds. So this is the whole iliac crest. So anterior two-thirds of the iliac crest on the outer lip, on the outer lip of the iliac crest, anterior two-thirds. Okay, so that is the insertion of this muscle. Apart from that, it also becomes, if you can see here, this muscle is changing its color. This is to indicate that it becomes aponeurotic. So it becomes aponeurosis. What do you mean by aponeurosis? What is the difference between the tendon and aponeurosis? In case of the tendon, the muscle will be getting inserted to a particular bone. In case of, and it will be a fibrous structure, as well as it will be condensed and fixed to one particular part of the bone. But in case of aponeurosis, it becomes fibrous and it becomes flat and fascia like, and it spreads and get inserted either into the deep fascia or to the opposite side. Here in case of this side, it will be getting inserted to the opposite side of the muscle, aponeurosis of the other side. So this is nothing but the modification of this muscle. It becomes aponeurotic, and instead of getting inserted to the bone, it goes superficially and get inserted to this line here, which is called as the linea alba. Linea alba is a midline structure. It is nothing but a line formed by the fusion of both the aponeurosis from either side, and this is whitish in color, and it extends from the xiphoid process up to the pubic crest here, as well as pubic tubercle. So this whole line is called as the linea alba. So this line is important especially for the surgeons. Previously they used to do surgeries on this linea alba because this is the least vascular area, so there used to be less bleeding, but it has many of its own complications. We'll discuss about that. Now they have stopped doing surgeries on this linea alba. Okay, so this is the linea alba on which this muscle will be inserted. It is not only inserted to the bone on the outer lip of the iliac crest, anterior two-thirds, but also a part of this muscle will become aponeurotic and get inserted to this linea alba, extending from the xiphoid process up to the pubic tubercle. A part of this muscle between this bony insertion and the linea alba will descend downwards, and it twists itself at this particular point, and it modifies this, especially the aponeurotic part, twist and turns inside, and this becomes a very important structure called as the inguinal ligament. A very important structure clinically. So this is called as the inguinal ligament. The lower border is thickened and folded to form the inguinal ligament, extending from the anterior superior iliac spine up to the pubic tubercle here. Okay, so this whole thing extending from the anterior superior iliac spine up to the pubic tubercle, this is called as the inguinal ligament. So inguinal ligament is not a true ligament, but it is just the modification, the aponeurotic part of the external oblique muscle. Okay, and what is ligament? It is connecting between the two bones. Usually it will be a fibrous structure. Okay, two ligaments which will be connecting two ends of the bones, or the two bones. Okay, but here in case of this ligament, this is not a true ligament, but it is part of the external oblique muscle. But because it is between the two parts of the bone, one is the anterior superior iliac spine up to the pubic tubercle, so that's why it is called as inguinal ligament. If not, it is not a true ligament, but it is part of the external oblique muscle which has twisted below. Okay, coming to the nerve supply, it is supplied, all the muscles of the anterior abdominal wall are supplied by the lower 6 thoracic nerves: If you can see this picture, so this is how it is supplied by these nerves: T7, T8, T9, T10, T11 and T12. So some books mention the lower 5 thoracic and the subcostal. Subcostal is nothing but the 12th thoracic nerve, that will be called as the subcostal nerve, because it is below the costas, the ribs. Okay. Going to the next muscle, that is the internal oblique. Once you cut the external oblique, deep inside we can trace the internal oblique. So the origin of this muscle and the direction of this fibers is, as the name indicates, it is internal. So that's why it is inside. That's what is called internal. Oblique. These fibers are also oblique, but it is just opposite to the direction of fibers of the external oblique. This is how we can identify this muscle. Okay. So what is the origin of this muscle? This will be taking origin from the lateral 2/3 of the inguinal ligament, as well as the anterior 2/3 of the iliac crest. Anterior 2/3 of the iliac crest. On the anterior 2/3 of the iliac crest, the external oblique was getting inserted, but in case of the internal oblique, this is the origin of this muscle. So it will be taking origin from the anterior 2/3 of the iliac crest, but in the middle part between the outer and inner lip, as well as the lateral 2/3 of the inguinal ligament. Lateral 2/3 of the inguinal ligament, and then it runs upwards. Okay, and then get inserted, especially in the muscle, into the lower 3rd and 4th ribs. Some of the fibers goes to the 3rd and 4th rib, and it also forms a broad aponeurosis and get inserted to the linea alba. Just like that of the external oblique, this also get inserted to the linea alba. And also it also gets, some fibers also get inserted to the 7th, 8th and 9th costal cartilages. Okay, so this is the insertion of this muscle, and the direction of this muscle will be, the muscle fibers will be just opposite to that of the almost at perpendicular to the external oblique muscle fibers. Okay, then deep inside there is one more muscle. If you cut the internal oblique, then you can see one more muscle, that is called as the transverse abdominis. So this is called as transverse abdominis because the fibers are almost transverse. Here they are called as oblique because they were oblique, but in case of the transverse abdominis, the fibers are almost horizontal on either side. Okay, so the origin of this muscle will be from the lateral 1/3 of the inguinal ligament. This was taking origin from the lateral 2/3 of the inguinal ligament. This will be taking origin from the lateral 1/3 of the inguinal ligament, as well as the anterior 2/3 of the iliac crest, but from the inner lip. Okay, that is the difference between the three muscles. The external oblique will be taking origin from the iliac crest, but outer lip. The internal oblique will be taking origin from the anterior 2/3 of the iliac crest, but from the middle part. And the transverse abdominis will be taking origin from the anterior 2/3 of the iliac crest, but the inner lip. So that is the difference between the three muscles, even though they are taking origin from the iliac crest. Okay, as well as this will be taking origin from the lateral 1/3 of the iliac crest, but in case of the internal oblique, it was taking origin from the lateral 2/3 of the inguinal ligament. So this will be taking origin from the lateral 1/3 of the inguinal ligament, as well as the anterior 2/3 of the iliac crest inner lip. So this will be the origin of this muscle. Then the fibers will run transversely, and again this also becomes aponeurotic and get inserted to the broad aponeurosis of the linea alba. So all the three muscles become aponeurotic and they get inserted to the linea alba from either side, and they fuse together. Okay, so they all from either side come and fuse at this particular point called as the linea alba. And all these muscles are supplied by the lower 6 thoracic nerves. Okay, then coming to the one more important muscle, that is called as the rectus abdominis. This is the rectus abdominis. If you cut the aponeurosis which is over this muscle, then you can see deep inside. This is how the rectus abdominis will look like. Okay, so this muscle is very typical that usually the muscles will take origin from the upper part and get inserted below, but this muscle will be taking origin from here because the mobile part is the ribs. Okay, this is fixed, so it will be taking origin from two heads: lateral from the pubic crust and medial from the anterior pubic ligament, as well as the tubercle. Okay, so it will begin as two heads, then join together and run upwards and get inserted to the 5th to 7th costal cartilages. Get inserted to the 5th to 7th costal cartilages, as well as partly into the xiphoid process also. Okay, so this is the origin here, and the insertion will be above. And this is also like other muscles, it is also supplied by the lower 6 thoracic nerves. These are the four muscles which are important muscles, which will be protective in nature, which will be sturdy, and which give shape to the abdomen: the external oblique, internal oblique, transverse abdominis, as well as the rectus abdominis. Apart from this, there are other two muscles which are very small muscles. One is called as the pyramidalis. As I said, it is a very small triangular shaped muscle, that's why it is called as pyramid. So this is called as pyramidalis. So it is triangular in shape, and it is said to be a rudimentary muscle, and it is just in front of the rectus abdominis in the lower part. So near the origin of the rectus abdominis, it will be a small muscle on either side again. So all these muscles are in pairs. Then the last muscle, which is seen only in case of the males, is called as the cremasteric muscle. Okay, so this is present in the scrotum. This is the testis here, and this testis is covered by a muscle which is an important muscle. This is called as the cremaster muscle. Okay, so this is seen only in case of males, it is not present in case of female. So in case of female there are 5 muscles, in case of male there will be 6 muscles. What is the function of this muscle? We'll talk about that later. Okay, now coming to the rectus sheath. Rectus sheath is nothing but the aponeurosis of all the 3 muscles: external oblique, internal oblique, and transverse abdominis, which will be covering the rectus abdominis. It is an aponeurotic sheath in front of the abdomen, covering the rectus abdominis muscle. So you can see here, this is nothing but the aponeurosis of the external oblique, internal oblique, as well as the transverse abdominis, which is covering this muscle called as the rectus sheath. If you see this muscle anteriorly, this sheath is complete from above onwards. If you can see, it is completely covering the rectus abdominis. But if you see posteriorly, and you can see that there are tendinous intersections. These are tendinous intersections which will be connecting the muscle rectus abdominis with the rectus sheath anterior wall. Okay, so if you want to strip this rectus sheath, then you will face this tendinous intersections which will be connected to it. If you see the posterior wall, this is incomplete. It extends from above, but as you trace it down, you can see here this muscle is cut rectus abdominis so that you can see the posterior wall. So if you can see here, this ends here in the form of an arch. This is called as the arcuate line, and below this there is no rectus sheath. So directly what you will be facing will be the transverse abdominis, the transversalis fascia. Okay, so the fascia will directly come in contact with the muscle. Okay, so this muscle rectus abdominis is cut to show you the posterior wall, which is incomplete. So it ends as an arch like fashion in the lower part, that is called the arcuate line, and below that there will be only the transversalis fascia, which will be in contact with the posterior surface of the rectus abdominis. Now we'll see how exactly this rectus sheath is covering this muscle. Okay, so it will be studied, we will see the formation of this muscle in the above the costal margin, between the costal margin and arcuate line, and below the arcuate line, how it is there. So here you can see the rectus abdominis muscle, the rectus sheath has been removed, and here the muscle also has been removed. So you can see the posterior wall. This is the posterior wall, and this wall is ending here in the form of arcuate line. Okay, so above the costal margin, if you see, the anterior wall is formed by the external oblique muscle, because this muscle will be in the front of this and extends. The origin of this muscle will be from lower 6 as well as the lower 8 ribs. So it will be covering this muscle also, and it will in the form of an aponeurosis, and this is the external oblique muscle which will be covering the upper part of the rectus abdominis, or it forms the rectus sheath. Okay, so the rectus sheath in the above the costal margin will be formed by the external oblique only. Okay, then posteriorly it will be deficient, because this muscle is getting inserted to the costal cartilages here, this rectus abdominis. So there will be no posterior wall, because it is totally adherent to this the costal cartilages. So only there will be anterior wall. Okay, between the costal margin and the arcuate line. Between the costal margin and the arcuate line, here is the arcuate line. So if you take a section at this level, then you can see this is how it is formed. So this is the section of the whole of the abdomen. You can see the posterior abdominal wall. This is the anterior abdominal wall. You can see the external oblique, internal oblique, as well as transverse abdominis. And here you can see the rectus abdominis, and these three are becoming aponeurosis, and they cover this rectus abdominis. And if you see it closely, you can see that the external oblique will be it becomes aponeurotic, and it covers the anterior surface of the rectus abdominis. Okay, it covers the anterior surface, so it becomes the anterior wall. If you see, trace this transverse abdominis, it goes behind it from the posterior wall of the rectus sheath. And if you see the internal oblique, this is typical that it comes to the lateral border, then it splits into two laminae. The anterior laminae joins with the external oblique aponeurosis and form the anterior wall of the rectus sheath, and the posterior laminae will join with the transverse abdominis aponeurosis, and it forms the posterior wall of the rectus sheath. Okay, so this is how the internal oblique splits into two. External oblique will form the anterior wall, the transverse abdominis forms the posterior wall of the rectus sheath, and the internal oblique will split into two, anterior laminae and posterior laminae. Anterior laminae will pass anterior to the muscle, and posterior laminae will go behind, and it forms the posterior wall. So this is how the rectus sheath will be covering the rectus abdominis. So the anterior wall of the rectus sheath is from the external oblique muscle, as you have seen, as well as the anterior lamina of the internal oblique. The posterior wall, as you have seen, this is the posterior wall, which will be formed by the posterior lamina of the internal oblique as well as the aponeurosis of the transverse abdominis. Okay, then below, if you take a section below the arcuate line, here is the arcuate line. So if you take a section at this below the arcuate line, then the posterior wall is deficient, and the aponeurosis of all the three muscles will join together, and it covers only anteriorly. So if you can see, the external oblique is forming the anterior wall, the internal oblique also joins with it and form the anterior wall, as well as even the transverse abdominis will go in the front, and it covers the rectus abdominis in the front only. So that's why the posterior wall is deficient, and you can see all the three aponeurosis of all the three muscles will form the anterior wall of the rectus sheath. Okay, so this is how it is formed at different levels. Okay, so below the arcuate line, aponeurosis of all the three muscles will form the anterior wall. The posterior wall is deficient, and it ends as an arcuate line. Okay, so this is the formation of the rectus the rectus sheath above the costal margin, between the costal margin, as well as the arcuate line, as well as below the arcuate line. So these are the pictures which are depicting the same. Okay, so this is in the middle part, and this is in the lower part. Okay, now coming to the contents. What are the contents of this rectus sheath? Okay, one we have seen already. One is the rectus abdominis. There are two muscles. One is the rectus abdominis. Along with that, this small muscle here, this also comes under the rectus sheath. So these are the two important muscles which are within this rectus sheath. So rectus sheath is nothing but the aponeurosis of all the three muscles, and it will be covering the rectus abdominis from anteriorly and posteriorly, except the lower part in the posterior wall, which will be deficient. So this rectus sheath will be having two muscles. One is the rectus abdominis as well as the pyramidalis. Along with, there are two important arteries which will be supplying this muscle. One is the superior epigastric as well as the inferior epigastric muscle, which will be supplying the anti-abdominal wall. Along with that, there will be two veins. One is the superior epigastric as well as the inferior epigastric vein, which will be running along with these arteries. Along with this, the main muscles the main nerves which will be supplying the lower part of the abdomen, that is the lower 6 thoracic nerves, which will be supplying this rectus abdominis as well as the other muscles. So these are the lower 6 thoracic nerves, 5 lower thoracic and the subcostal. As I said, it can be said as lower 6 or lower 5 intercostal as well as the subcostal below. Okay, so these are the nerves which will be forming the content. So these are some of the contents of the rectus sheath. Two muscles, rectus abdominis as well as the pyramidalis, two arteries, superior and inferior epigastric artery, two veins, superior and inferior epigastric vein, as well as 6 thoracic nerves, lower 6 thoracic nerves. So what is the main function of this rectus sheath? One is it maintains the strength to the anti-abdominal wall. When you do the gym at that time, you can see the six packs. This is where you can prominently see, and the six packs are because of this tendons intersection, where this part of the muscle is bulge and the remaining part here where the tendons intersections are there it will be depressed. So that is how you can see the six packs, and this will be giving strength to the anti-abdominal wall, because all other muscles are horizontal, almost horizontal, and this vertical muscle, and this sheath will be covering this important muscle here. Okay, so it will be giving the strength to the anti-abdominal wall, as well as it also prevents the bowing of the rectus muscle. When you bend in the front, forward bending, if there is no rectus sheath, then this muscle will fall in front. Okay, it will it will be projected in the front. So this is prevented by the presence of this rectus sheath, which will give the strength to this muscle, as well as it prevents bowing of the rectus muscle. Okay, so these are some of the important functions of the rectus sheath. So this was all about the six muscles of the anti-abdominal wall as well as the rectus sheath.